Good morning, good afternoon, good evening, everybody, from wherever it is that you are joining us. It is my great pride and joy to having and hosting this webinar. I have wanted to do it for a very long time, and finally we are there. It's an extremely important time and date to have this webinar. Today, the first shipment of vaccine backed by COVAX has reached Ghana, the first lower-income country to receive it. So it's quite an historical day for us to have this conversation. I have been taking part in the COVAX and ACT accelerators meeting since June last year, and doing so has given me great hope that we may be able to get out of this pandemic. But it will only happen if we all get vaccinated. And so here with me today are a number of great speakers. Next slide, please. And I am going to ask each of them to speak at this webinar. Before we do that, I want to tell you a little bit about who we are on this webinar today. We have representatives joining us from 85 countries. You can see what are the largest groups. We have medical professionals and staff and volunteers of Alzheimer's organization, people who are in education and research, media, people living with dementia, carer, industry, and formal carers. Please, next slide. Now, whilst I'm going to give you a few pointers about this webinar, I also want to draw your attention to this slide. It's very packed with resources. This is just to let you know that you don't have to do this now. Slides will be available from tomorrow. The webinar is being recorded and everything will be made available publicly. And this simply is to tell you that we are going to have the opportunity for you to go and explore further in the great resources that have been created for all of us. Now, I need to remind you that we are going to take questions. There's going to be two ways. We are going to have a question and answer capacity where you can send your question. We also have a chat. In the chat, please just tell us who you are if you want to tell us which country you're from. But the questions should go in the question and answer session. And once again, everything will be available because it's being recorded. Next slide, please. Please remember that we are a charity. We make everything we do free of charge. But if you could donate, if you can spare some money, that would be something that we would be very grateful. So we will continue to be able to do that. Thank you. Next slide. Now, let me tell you a little bit about the speakers with me today. We have Dr. Shalini Desai, who is based in Switzerland, who is the medical officer of Immunization, Vaccines and Biologics departments at the World Health Organization, who has prepared an amazing presentation, who I hope once and for all will clarify for all of you what's happening with vaccines globally. Then we have asked the perspectives from our members. From the UK, we will have the wonderful Fiona Carragher from the Alzheimer's Society in the UK, the Director of Research and Influencing, who has had an incredible role in persuading the British government, which as we know is one of the fastest one in the rollout of vaccine, to prioritize our constituency. We'll also hear from Dr. Jennifer Bute in England, the founder of Glorious Opportunity and a member of Dementia Alliance International. Dr. Jennifer Bute, who used to be a general practitioner, as a family doctor in England, is living with dementia, and she will tell us of her experience from her perspective. She lives in a dementia village in England. Next slide, please. And then we are going to look at also an important, very important perspective from Jackline Kiarie in Kenya. We will hear about their experience of COVID-19 response program. As I say, this is crucially important that everybody gets vaccinated. So it's important to see the point of view a country like Kenya. COVID-19 has been very prevalent. And once again, I send my best wishes to the chair of our program in Kenya, Elizabeth Gitonga Mbale, who has herself had COVID-19. From the Latin American perspective, we are going to have Dr. Patrick Wachholz, who is speaking to us from Sao Paulo state, and who will tell us about the experience in Brazil. Now, next slide, please. So without further ado, I am going to introduce you to Dr. Shalini Desai, who will speak about the important points on vaccination. And I hope that there will be a robust series of question and answer. We are trying to get them at the end. Thank you. Shalini, the floor is yours.
Okay, great. And Paola, thank you so very much for those kind words of introduction. And thank you so much for having us here. We're so excited to be joining this webinar. Jean, were you going to put up my slides or shall I? Oh, I do the page down. Got it. Okay. So when Jane asked that I speak today, when Paola asked that I speak today, we talked a little bit about what would be of interest to people on this webinar. And as she showed you, the different constituents that are on the call today have potentially different needs. So I'm hoping that as we go through the slides, there are 5 big areas that I'll be touching upon. The reference list, the resource list that Paola provided right at the beginning of the presentation has an abundance of information that goes into a lot more detail in each of these areas, but we'll go through a COVID-19 overview. We'll look at the vaccine pipeline as well as vaccine deployment. We'll look at safety and what happens as we continue to roll out vaccines in terms of safety. And finally, we'll look a little bit at public trust. Okay, and just a reminder for anyone interested in any more detail than what I'm able to provide in the next 20 minutes, please feel free to visit our website. There's lots of information available there. Jane, the slides aren't moving. Let me see if I can make that happen.
We've been trying to do a automatic progression of slides because Shalini's slides are very full of information so that she could point things to us. Shalini, try now.
If you just click on the slide.
We'll click on the slide, okay. There. Okay. All right, so we'll start off with an overview of the current COVID-19 situation. So as of, oops, we ended up a little too far. Let's see if this works. Okay, so as of February 7th, 2021, over 150 million cases of COVID-19 have been reported globally. Over 2.3 million deaths have been reported, and in the figure in the middle, what you can see is that every region of the world has been affected, and the epidemic curve, based on region, is a little bit different. The other thing to point out here is the black line here gives us the number of deaths that are reported by countries to WHO. When we look at the age distribution of cases of COVID-19, this is for the year of 2000, we see that we have a disproportionate number of people within the age groups of 15 to 64 that are affected. But when we look at the number of deaths, what we see is that individuals that are represented here in the color blue, I'm hoping that you guys can see the legend. I can't see it on my screen, but I'm hoping that you can. It's individuals over the age of 65 that are most affected, and in countries that have a large number of long-term care facilities, over 50% of those deaths are actually in those long-term care facilities. And so for individuals living with dementia, if they're in those care facilities, they're at a higher risk. So I'm going to move on now to the vaccine pipeline. So this next slide is a little bit busy, but let's go through it together. So I do have a pointer. So we're going to talk first about vaccine development. Typically, when we talk about vaccine development, we talk about preclinical testing, clinical testing, and then we talk about post-marketing or monitoring, which is phase 4. We'll go through what happens normally, and then we'll talk about what happened for the SARS-CoV-2 virus. That's the virus that causes COVID. So in the preclinical testing phase, usually companies or academics or anyone that's interested in making a vaccine start off by testing different antigens and testing potentially different adjuvants. Adjuvants are the things that sometimes can help make an immune response more robust than just the antigen. The testing is usually done in animal models, And we usually use information from related viruses to help us along the way. This process normally takes 5 to 10 years. Once that happens, we have a candidate vaccine that then goes into clinical testing. Clinical testing occurs in 3 different phases. The first phase, often what we do there is look for dose testing. So how much of the vaccine, the antigen and adjuvant, does one need in order to get an adequate response? Usually it's just a small number of volunteers, and it can include some at-risk populations. Once the dose is determined, then we go on to phase 2 testing. It usually involves a larger number of volunteers and at-risk populations. Phase 3 involves even a larger number of individuals and generally is within the overall population. That process can take anywhere from 5 to 10 years as well. And that's the usual timeline that we undertake for vaccine development. So if you look at any of our past vaccines, they typically fit within this. And obviously there's some that take much longer, and there are a few that have been shorter. And the one big exception is COVID-19. The reason for that isn't because any of these steps were missed or not. Rather, what happened was that the resources in terms of people, laboratories, and the willingness, because of the impact that COVID-19 has had, has led to an accelerated pace where a number of these steps have taken place simultaneously. We're going to come back to look at the monitoring phase, because not only do we continue to monitor the effectiveness of a vaccine after it's out of clinical trial testing, but we also continue to monitor safety, but we'll go to that later. So this is the COVID-19 vaccine pipeline. Along the left-hand side of your screen, you'll see the different platforms that have been used to try to come up with these vaccines. A number of them are in preclinical trials, as well as phase 1, 2, and 3, and 10 of them have received regulatory authorization by a country. These vaccines are listed here. Unfortunately, due to time, we're not going to be able to go through each of the different platforms, but at the bottom here, I have a link to a Nature article that is really helpful in terms of going through each one of these platforms. Oops, we went a little too far. Okay. It's very sensitive. So this slide has the status of COVID-19 vaccines within the WHO. EUL just stands for use licensing, and then PQ is pre-qualification evaluation process. So as I mentioned in the last slide, regulatory authorities within countries can provide information, can be provided information by companies in order to allow use of vaccines in country. Not all vaccines that are developed go through WHO. So WHO has a process for pre-qualification. That's what we call that regulatory process that vaccines can go through, but it's up to a manufacturer to decide whether they'd like to have a product go through pre-qualification. I've got all manufacturers listed here in the first column, the product name listed in the second column here, and whether the manufacturers put in expression of interest in order to have their product pre-qualified. In order to do that, what they will do is they will submit a dossier, so all of the information that they have related to their specific vaccine product, as well as what they received from the regulatory authority from wherever they received regulatory authorization. This column provides status of their WHO pre-qualification and when we anticipate WHO pre-qualification. So just as a reminder, not all vaccines go through the pre-qualification process. And so if there's a product that hasn't gone through pre-qualification, WHO has no way of knowing how well it protects or any of the safety issues related to it. Okay, we're going to move on to vaccine deployment. Today, as Paola mentioned, Ghana received their first shipment of vaccines. So this was taken from Our World in Data, and it was from February 15th. So unfortunately, I don't have Ghana highlighted here, but it should be. Well, they were shipped. I don't know if they've already started their program or not. And what we can see is that a number of programs have already gone ahead and started to roll out vaccines. This is the number of doses administered per 100 people. So for the countries that aren't highlighted here, what happens? So I want to talk a little bit about the ACT Accelerator. As Paola mentioned, she's been participating in these conversations since June of last year. So the ACT Accelerator is a global collaboration that's meant to accelerate development, production, and access to COVID-19 vaccines, diagnostics, and therapeutics, as well to look at distribution of COVID-19 vaccines, diagnostics, and therapeutics so that they can be fairly distributed around the world. ACT-A brings together governments, scientists, businesses, civil society, philanthropists, and global health organizations. I won't be talking about the diagnostics and therapeutics pillar, but as I said, all of this information is available on our website, but we will talk about the COVID-19 vaccine portion. So the ACT-A aims to deliver 2 billion doses of vaccine globally by the end of 2021. And the way that we intend to do this is through the COVAX facility, which is part of the ACT-A vaccines pillar. The aim of this facility is that all participating countries, regardless of income level, will have access to COVID-19 vaccines. 190 countries have signed up for the COVAX facility, some of which are self-financing countries, and there are also 92 countries that are funded. These 92 countries are eligible for financial support through the COVAX Advanced Marketing Commitment. The overarching principles to ensure equitable access to health products in the context of COVID-19 follow the following principles, which are solidarity, accountability, transparency, responsiveness to public health needs, equity and fairness, affordability, collaboration, regulatory and procurement efficiencies. So when we're thinking about vaccine allocation, COVID-19 vaccine allocation is guided by public health objectives, along with the other principles that we just talked about. For the initial phase, these objectives are to reduce mortality and protect health systems. They're to maximize the health impact of a limited supply of COVID-19 vaccines. They will target high-risk groups such as older individuals and people with specific risk factors to reduce severe disease and mortality, as well as health workers to protect the health system. These groups correspond to approximately 20% of the global population, and therefore the first phase of COVID-19 vaccine allocation will be up to 20% of a country's population. We're going to move on to vaccine safety. If you remember in the busy slide that I showed you in the beginning, where we looked at how vaccines get rolled out, this would be the final phase, which is the post-marketing or the monitoring phase. So for all the clinicians and care providers out there, we'll just go through a little bit about vaccine safety and some specifics that hopefully will be helpful to you as you're helping people living with dementia make the decision to become vaccinated. So vaccine safety is a program that we roll out with any of our vaccination programs. And so most countries have robust programs for vaccine safety that go along with our childhood immunization programs. The goals of these are to prevent, identify, report, and handle adverse events following immunization. So for providers for COVID-19 vaccine, what we ask is that you first start by asking, has someone had severe allergic reactions? The second step is to assess if there are any other health or medical conditions that may be precautions to be vaccinated for COVID-19. The third step is to communicate some of the side effects that can occur. Some of these can occur days after being vaccinated. And just as a note, for individuals with living with dementia, the communication may need to be with caregivers, and they may not present with the traditional side effects that I have listed here, but nevertheless, they may be experiencing them. So it would be important for caregivers to just be mindful of when that vaccination was received. Oops. Sorry, I went too fast there. There we go. Then Step 4 is to vaccinate. And after vaccinating, we do ask that people be observed for 15 minutes if they've had reactions before, for 30 minutes. And as I mentioned, vaccine-related events can happen anytime thereafter. Well, adverse events following an immunization can happen immediately, but also more long-term. So if any of these happen, it's important to inform a healthcare provider or somebody at the vaccination clinic. This is a bit of a busy slide, so I'm going to walk you through it. So adverse events following immunization usually get reported by health providers, by nurses, doctors, patients, as well as parents or caregivers. And what happens is we have a standard AEFI form for reporting purposes. All of that information is put together into a line list, and additional information may be collected in the form of a dossier. That information then gets put into our standard AEFI surveillance system that exists in country. Each dossier is then reviewed by an AEFI committee to determine whether the event that was reported was related to the vaccine or not. Because you can have events that are temporally related, so they may happen after vaccination, but they're completely unrelated to that vaccination event. All of this information, once that causality assessment is done, end up in this bottom area here, which is your global database. And that's how we're able to monitor vaccine safety globally. Okay, I'm going to move on now to public trust. So this was taken from a survey that was done by Ipsos Reid. They did one survey in December of 2020, and they did a second survey in January of 2021. What I'd like to mention too is that this was across 15 different countries, and they used a Likert scale for the statement, if a vaccine for COVID-19 were available, I would get it. You could answer strongly agree, all the way through to strongly disagree. Where I'd like to focus your attention right here, changed since December 2020. And what we see is over time, there's been a change for more people to strongly agree with that statement. And what that suggests is that early success with vaccines is building public confidence. And it suggests that hesitancy is not driven by the public buying into conspiracies, but is more likely to be thoughtful people being hesitant because they don't have the information that they need. So this brings me to the infodemic, and some of you may have heard this term used before. It's the tsunami of information, some accurate, some not, that spreads alongside an epidemic or pandemic. Managing the information has become more challenging with the rapid spread of mis and disinformation through social media. In some countries, misinformation has generated mistrust in governments, public health authorities, and science. Managing the infodemic is critical to managing this pandemic. And so what can we do? There's a number of things that we as individuals can do. We can debunk rumors, we can have engaging messages, and we can amplify information from trusted sources and trusted individuals. So in summary, COVID-19 has disproportionately affected older individuals, including those living in long-term care facilities. Vaccine supply is limited at present, but new vaccines continue to be developed and tested. Vaccine deployment is occurring through the COVAX facility. Vaccine safety continues to be monitored as COVID-19 vaccines are being used. And we can all work to build public trust by reading and referencing trusted sources to stop misinformation from spreading. Thank you.
Shalini, I really cannot thank you enough. I know how complex it's been to put a presentation that has been so dense with fantastic information in such a clear, simple manner. I'm sure that many that are listening to this webinar will want to go back and explore it further. Can I also remind you that Shalini has given us a lot of further resources that you can also explore. Now, whilst Jane is taking on this presentation over again, I would like to tell you that we are going to run two polls now. And Jane is going to run the first one right now in order to facilitate the second half of this webinar. The first one, we are going to ask you quickly, is there a COVID-19 vaccine available in your country? Yes or no? We have 85 countries online, please. I'm going to give you a few extra minutes while Shalini is getting a lot of wonderful praise in the chat line for her fabulous presentation. And I will remind everybody, please send us questions. Now the poll is done. No, 95% of people say yes, but there is 5%, unfortunately, they still say no. For those that have said no, please do let us know in the chat line who you are so that eventually we can get back to you. Now we are going to have a second poll right now. The second poll is going to be about whether are the most vulnerable going to be prioritized for administration of the vaccine in your country. And this relates to right now. Do you know if the most vulnerable are going to be prioritized for administration of the vaccine in your country? Yes or no? Once again, we're going to leave a few minutes. So whilst we reflect on the presentation of Shalini that touched on such important issues, misinformation, safety of vaccine, the typology of vaccines, and what is in the pipeline, please do send us your question. The poll result is 96% say that yes, the most vulnerable are going to be prioritized. Well, that is a wonderful news. 4% say no. Once again, if you are in the 4% that say no, please do let us know in the chat line who you are so that then we can have separate conversation. Thanks so much to everybody. This has been terribly helpful. I now have the enormous pleasure of handing over to Dr. Fiona Carragher of the Alzheimer's Society. Fiona, the floor is yours.
Thank you, Paola, and hello everybody from England. I'm going to speak to you around what's happened in the UK, and I think comes very clearly to what we heard just earlier, is that how people with dementia have been so badly affected during this virus. Not just in terms of deaths. So, for example, in the UK, we've had over 120,000 deaths from COVID-19, and over a quarter of those have been from somebody with a pre-existing dementia. But after the first wave last year, we surveyed over 2,000 people in July 2020, and what we revealed was that not only was there an impact in terms of excess mortality, but actually we'd seen a deterioration in symptoms for those living with dementia. 4 in 5, so over 80%, had reported a deterioration during that first lockdown period, with many reporting memory loss, difficulty concentrating, issues with reading, with writing, understanding speech, and a quarter saying that they've seen a loss in ability to do daily tasks. So significant effects in terms of mortality, significant effects in terms of the impact on cognition and skills, but we also found a huge effect on the families and friends and carers around those with dementia. So in that first kind of phase last year, an extra 92 million hours were spent by loved ones, unpaid, to care for those with dementia, with 95% of those family carers reporting a significant impact on their mental and physical health. So we've seen a huge impact in the UK, and when we think about care homes particularly, so those in residential care, 26,000 people have now died in care homes in the UK, many of whom will have had dementia. And at the beginning of our pandemic last year, there were attempts to protect those care home residents, but it fell very, very short. We've also seen that care homes have stopped visiting for a very long time now, which has had a real detrimental impact on those with dementia. Because as all of us know, family carers have a huge part to play in that care system, helping with practical elements of care, supporting the communication, that advocacy, companionship, love, is really, really important. And as family carers have been unable to provide that vital care, what we've seen is the health and well-being of people with dementia decline. So again, people with dementia have deteriorated and declined, not just because of the pandemic, but because of the secondary impacts of the pandemic. So in the UK, we've always seen the vaccination as critical to kind of our route out of the pandemic. And in the UK, we were first to be able to use the Pfizer vaccination. And today, over 15 million people in England have been vaccinated. And there's a huge amount of preparation that came to make that happen by the UK government. We had a vaccine task force that was set up to work with our research institutions to help speed up the kind of everything that we talked about in terms of the different phases of getting to a vaccine, but also thinking about procuring the vaccine that was needed. We had huge impacts and a real cross-section of society coming together, our NHS, our health system, our armed forces and local and regional governments to make that rollout successful. And most of our vaccinations have been done in mass vaccination centres. Last year, the UK government, through its Joint Committee on Vaccination and Immunisation, which is essentially our advisory group on vaccines, advised that the first priorities for the programme should be to prevent mortality and to maintain our health and social care system. Because one of the major concerns that we, like many of you have been that our health systems are just overwhelmed with those getting ill with the virus. So that means that our prioritisation has been largely done on an age-based approach. But in that first tier, the first ones getting the vaccine, care home residents and frontline health and social care workers were prioritised. We also, the UK, through this joint committee, decided to prioritise delivery of just the first dose. So normally you would expect one dose and then a next dose 3 or 4 weeks later. But in this country, we decided to focus just on that first dose to as many people as possible to have that greater public health impact in the short term and reduce the number of preventable deaths. But it did mean delaying that second dose for up to 12 weeks. And we are very concerned at the Alzheimer's Society to make sure that that second dose happens and that it is still continuing to see high uptake of that second dose as it rolls out. So all of that has had an impact. I talked about care home residents having the most significant impact in terms of deterioration of symptoms, but also mortality. And we were really pleased to see that group prioritised and had worked to ensure that group was prioritised within that first tranche. What we've shown data as of last week, that nearly 95% of residents in care homes have now had at least one dose of either the Pfizer or the AstraZeneca vaccine. We do have a concern, however, around care home staff because they were offered they have been offered the vaccine in that first range, but only just under 70% of care home staff have been vaccinated to date. And we know that this is a really critical population when we think about the transmission of the virus within those care settings. So one area for our influencing and our advocacy is around ensuring that we have the data and everything is being done to really think about those care home staff that are hesitant to take up the vaccine. So more broader than that, we've been also concerned about those with dementia living in the community, particularly thinking about those that live alone or don't have the support systems nearby, so that invitations that have gone out to them are not falling through the cracks, they are being actioned. So we still are concerned and working very strongly on ensuring that that community-based support is given. And for that to happen, we need to ensure that local systems are able to identify those with dementia who haven't responded within that first invitation and arranging that human face-to-face contact. Linked to that is those carers that live with people with dementia, because at the moment they are not being prioritised within our specifically being prioritised within our rollout. They may be because of their age, but not specifically because of being a carer. And that's a concern, because if you think about even just the logistics of ensuring that you are vaccinated as a family unit, and also if a carer gets COVID-19, they wouldn't necessarily be able to provide the care. And as we've seen right from the beginning, those family carers have been critical for the support needed to those with dementia. So from the UK perspective, we have been really pleased to see the rollout of the vaccination. It's been such a dreadful time for those with dementia in the UK. Really great uptake amongst residents within care homes, but much more needs to be done around those people caring for them, particularly staff within residential care. What's become clear is that we need to have better data to understand vaccine hesitancy, and this might be something, Paola, we come on to as a question, but we can't leave behind those living in the community who haven't been specifically prioritised because of their dementia. But any learning that we can give, we've got lots of information on our website. Please do get in touch with us at the Alzheimer's Society. Thank you, Paola.
Thank you so much, Fiona. That has been such a fantastic slide. It's one slide, but there is so much. And there is months and months of very hard work and sweat for everybody. Now, it's going to be my pleasure to hand over to Dr. Jennifer Bute, the founder of Glorious Opportunity, a retired GP, which is a family doctor in the UK, a member of Dementia Alliance International, who is herself living with dementia in a dementia village in England. Jennifer, the floor is yours.
Thank you, Paola. I've lived almost 10 years in a dementia inclusive village in Somerset, one of 5 run by the charity St Monica's Trust, with our own nursing home and advanced dementia unit, and the staff have been brilliant. But we did not know at the beginning what we know now. Staff attitude has been amazing throughout, even with constant absences from frequent quarantining, illness. St Monica's Trust even took on 50 additional staff across the 5 sites to cope with it. Slide 2, please. They provided regular, frequent communication. No need for gossip or conjecture. It gave us confidence. Beginning of March, we were sent information about COVID-19 and hand washing. And a few days later, reassurance they were stocking up on PPE and hand washing foam and gels. The first UK lockdown followed, and I remember I was just leaving to give a dementia talk, cancelled. When cases were confirmed on another site, we were informed. Visits to all nursing homes, other units were stopped, each isolated. All outings cancelled. Hairdresser, gym, restaurant closed. Meals had to be delivered. All arranged social interactions ceased and people were not happy. In fact, so unhappy, the end of March, guards were stationed on our gates between 9 AM and 5 PM. Visitors had to pre-book, but some cheated, so the hours had to be extended a bit. But at the beginning of April, first cases were confirmed in our advanced dementia unit. We were given instructions on making face coverings, but not to wear them. Booked visitors had to be met outside in one of 2 designated places in 2-hour slots. Only when cases on other sites began did staff begin to wear masks. PPE was only for confirmed cases and we were no longer allowed to visit other residents. I had regularly visited so many and the nursing home and advanced unit, and I feared for them, but I tried to encourage in other ways. I remember once hearing music blasting out across the grounds from the advanced dementia unit. Even those in bed could hear. Wonderful. Made one feel part of a community again. But only in June, 2 months later, were masks mandatory for staff at all times. All visitors were cancelled, and anyone living alone like me could register an unalterable social bubble with one person or couple. Only in July were face masks mandatory for residents. Some of us were already wearing them. but some were not willing. Well, their hearing aids got hoiked out when they took them off, so why should they? I distributed posters on how to communicate well while wearing one and how not to wear them. Humour and peer pressure helped. And we had a wonderful summer. St Monica's Trust provided a large marquee outside with socially distanced activities, and once delivered scones, clotted cream and cream, jam to us all. I ran my Japanese memory groups and a poetry group by Zoom. Staff helped the residents with the IT. Let's stop the slides just for a moment. Spouses were not allowed to visit in the advanced dementia unit, only waved through the windows. It seemed cruel. But some spouses were still going to the shops and they could have taken an infection and they were angry. And some with advanced dementia couldn't cope with the Perspex pods that were eventually installed for booked visits. So many spouses chose to permanently stay away. It was just too painful. But none bedbound residents from there were taken out in the gardens in wheelchairs to enjoy the sunshine by staff in their coffee or lunch breaks. They didn't have to do it. We were allowed out once a day for exercise. And I'd often see them and the staff would say, they don't talk anymore. Well, I would smile and give context and reassurance. And much to staff's surprise, they would begin to speak. But as time went on, it became more difficult. It's one of my specialties, getting people with advanced dementia to speak. They had seemed so aged. One day at the end of summer, nothing seemed to work. I tried so hard. And as I stood up from squatting for eye-to-eye contact, I said, wonderful to see you. And I heard a voice say, you made my day. The staff could hardly believe it. But so sad that no one was spending individual time constantly enabling speech. Music was continuing, so important. I dread what it'd be like when I go back. Okay, 12 had died in March, none since, but what a price to pay. And then I had an unexpected hospital admission in September. Immediately transferred for urgent neurosurgery. I'm used to hospitals, but when I came around, my dementia took over. I was in for 9 days, then I had to isolate here for 14 days, and the NHS sent in physios, nurses, carers twice a day to get me up, wash, dress, change my dressing, 2 hourly exercises. I had to learn to walk again, but I had to fight for permission to allow my social bubble sister to stay during that time and the next 2 weeks. I could never have managed without her. After that month, the marvelous staff came 3 times a day, decreasing over the next 2 months. I'm fine now. Beginning of the second UK lockdown, we had our first cases in our building, followed rapidly by 6 more. Eventually 12 of us in this building got it and 4 died. It was brought in by 1 person before they had symptoms with a negative COVID test 3 days before. But there was never any panic or fear. The outwardly calm staff in their PPE were amazing. There've been no cases since. And mid-December, visiting was allowed in our advanced dementia unit for relatives in their own rooms if they'd had a negative test that day. So much better. But Christmas Day, so many of us chose to meet with nobody. Let's have slide 3. Beginning of January, the doctors came to give the vaccine to all residents in the nursing home and the advanced dementia unit. And there have been cases there since, but they're still taking in people from hospital in the community. But no one has died and none have been seriously ill. The vaccine has definitely made a difference, just 1 dose. But we couldn't understand why the doctors didn't come and do us in these buildings. But at the beginning of this month, our invitations began to trickle in by post or phone. We had to find our own way to one of 4 vaccination sites between 2 15 miles away by our own car, if we had one, family or support bubble. Well, my sister's stuck in Dubai, my son's in Ukraine, my daughter's in New Zealand. But the parish council laid on a community minibus manned by volunteers. We've had thousands of volunteers who've done so much throughout the country. And then everyone compared their side effects, including not being able to get warm, which is definitely a COVID-19 symptom. Most only lasted 48 hours, but I've recently heard of 2 that lasted a lot longer. But the mood so improved, so nobody minded the transport problems, the queuing in the rain, unpleasant side effects. It reassured people. They might have died if they had the real thing. Slide 4. So what were the lessons that we've learned? The importance of regular communication, education, masks, testing, enforcing restrictions. But no one had realized transmission was possible before the symptoms appeared, and that a negative test was only relevant on that day. It's going to be a lengthy challenge helping people to catch up and restoring bent relationships. We have done our best this last year, and St Monica's Trust have been so good. But we've also experienced the positive effect of peer pressure and the power of small things. I've loved leaving daffodils in jam jars outside people's flats, not allowed to go in. And one person left me a Brussels sprout tied up with a ribbon in a jam jar. I'm so grateful. Wonderful. That's it.
Jennifer, sorry, I was muted. I cannot thank you enough for this presentation. I think after we heard the Fiona talk of 27.5% of all people dying with COVID-19 had dementia, and the vast majority were in long-term care facility, to have your vision of what actually happened from your viewpoint to those long-term care residents must have felt under siege positively during that period, and also the way that you have had to cope with the isolation, which of course has been a massive issue, has been really heartwarming and sobering. Also, you being a doctor yourself, it must have been quite interesting, as you were saying earlier, as people didn't realize that having a negative test on a day just means that at that moment in time you don't have it, but you could have it the next hour. So for you, it must have been so frustrating knowing full well that that would have been the case, to see that unfold as it has been for many of us. I think we've all had to learn so much from this pandemic. So thank you very much for your testimony. Lots of wonderful messages are arriving in the inbox for you. Now, can I pass on to discussing the other side of the spectrum, which is what happens in lower income countries and in middle income countries with this pandemic. As I've said at the beginning, one of the reasons why we're doing this is that there is still a huge amount to do to make sure that everybody gets vaccine and that the vulnerable get it first all over the world. It's only when that will happen that we will really start looking at the possibility of a path back to what we call normality. So I invite now Jackline Kiarie, who is the program manager, COVID-19 response program for the Amref Health Africa, to address us with her experience. Jackline, the floor is yours.
Thank you very much. I believe you can hear me.
Yes, we can.
And thank you, Jennifer, for sharing your story. I really wish we could be able to tell, our older persons would be able to tell a similar story. Unfortunately, that's not the case here in Kenya and for most of Africa. So I'll share the story of Africa. I will use the case study of Kenya to really explain how far we have gone in the COVID-19 response, how it's affecting the older persons, and the preparations that we have made in preparing for vaccine introduction in the region. Next slide, please. So I work for Amref. It's one of the largest Africa NGOs that we have here in Africa. We work in around 35 countries, and therefore we get a feel of what's happening in each one of these countries. We have about 54 countries in Africa, just to bring everything into perspective, and we've been around for the last 60 years. So allow me to share the experience of Kenya. Please move to the next slide, because I have just about 5 minutes. So like I said, we have 54 countries, and 35 countries out of the 54 are already making preparations for the vaccine introduction. But just to let you know how we have been affected by COVID-19 as Kenya. So we have a population of about 49 million people. And so far we have, I'll say only about 100,000 people infected with COVID. I say only because when we compare with the rest of the world, it looks like Africa has been spared in as far as infections are concerned, but we cannot say the same in as far as the economic and the social economic impact of COVID in the region. So out of that population of about 49 million, 5% are elderly persons in Kenya. I believe the spread is more or less the same in the rest of the African countries. And what we are seeing on this graph here is that 17% of all the cases that we have are for people who are 60 years and above. And these are the people who've been categorized as older persons that we have here in the region. And I think it's the same case across the region. Males are more affected than females. And what we are seeing is that 5% of the population, which is just about 2.7 million people, are contributing to 17% of the cases. So while the numbers might be small, we actually have this cohort of the population getting affected a lot more than what we have with the rest of the population. Please move to the next slide. When we come to the case fatalities, in other words, those who are dying out of the ones that have been affected, we are seeing that 46% of those who have been infected are elder and dying of COVID are the older persons. If you look at that graph, the last bar there is the one that is presenting the older persons. We have males being more affected than females. A few reasons have been fronted for this, perhaps because they have compromised immunity. We have comorbidity, so we have quite a bit of our older persons living with diabetes, with hypertension, and cancer cases are also rising. Most of them live in the rural areas. Most of their relatives have moved to the urban areas, so most of them live alone, a lot of loneliness, very weak social protection mechanisms. In Kenya, for example, our older persons get about $20 per month. It's not reliable supply. Sometimes they get it, sometimes they don't. And out of that $20, you are expected to get all your basic needs from that, access medical care from the $20. So just to give you a feel of how bad sometimes the situation can get if your relatives are not coming around to see you. So that's the case that we have here in Kenya. We have a lot of, about 17% of all those dying being people of the older persons. Please move to the next slide. So a little bit about how far we have come in as far as preparing for the vaccine in Kenya. So out of all the 54 countries in Africa, we have about 35 that have already submitted their deployment plans, which is a core requirement before any country can be able to import and really introduce vaccines in the country. So Kenya is amongst those countries that have made quite a bit of progress in preparing for the vaccine. We already have our deployment plans in place. We have proper coordination mechanisms. We have national task forces. We have task forces at the regional levels, at the county levels that are really making sure that systems are in place as we prepare for vaccine introduction. We have already mapped out the populations that should be given priority in as far as vaccine access is concerned. We are going to provide our vaccine in 3 phases. We have phase 1, which begins now. We expect our vaccines from next week. We are prioritizing our healthcare workers and our community health workers, as well as our uniformed forces. Phase 2, which should begin sometime this year in July, is where we have our older persons coming in. These have been mapped, and we know how many they are. We have about 2.7 million of them. They are in the rural areas, and they'll be able to access their vaccine from about July this year. And then after that, we have our phase 3, which begins next year. And at that point, to be expect that we're going to have enough supply of the vaccine and most of the population will be able to get it. So altogether, we think we're going to have about 40% of the population getting immunized. So it's not everybody who's going to get it. We are getting our vaccine from the central Gavi COVAX facility, which is the case with most African countries, even if we are opening this up for the private sector here in Kenya. And we're also looking for other mechanisms through which we can be able to get our vaccine to ensure that most of our population can be able to get it. So to summarize, we faced our vaccine rollout. We have phase 1, phase 2, phase 3. Elderly persons are going to be able to access the vaccine from July this year. And we are getting prepared. We have the right mechanisms in the country to make sure that that happens in the right way. Next slide, please. That said, we already know who the older persons are, but we've not been able to segregate the different cohorts within our elderly or our older persons, mainly because we've not had quite a bit of priority being given to the older persons here in the country. As we speak, we are in the process of developing our National Dementia Action Plan. It's not yet rolled out. Our people have not been sensitized on that. So like I said, not quite a priority, but the best part is that they've been prioritized and they'll definitely be getting the vaccine. We have a few worries as a country. So for one, it's going to be rolled out in the higher level health facilities. That's from the district level upward to the national level health facilities. And when you think about where our older persons are located, they are deep in the rural areas, very little access to the high level health facilities. So it's going to be a challenge for most of them to get to the health facilities. So that's a concern for most of us in as far as ensuring access, equity in access for our older persons. Remember, they only have about $20 per month to work with for their basic needs, for their health care. And even if the vaccine is going to be free, there's still a cost associated to get into the health facility, the kind of diet you have to maintain. So a lot of concern around that. The second one is around the way the vaccine is going to be administered. In Kenya, we have prioritized the AstraZeneca vaccine for the phase 1, which begins sometime next month. It's going to be delivered in 2 doses. So when you think about our older persons who are located in the village, if you make it to go to the health facility, you will make it the first time round, but you're likely to have quite a bit of loss to follow up, because we expect the same person to show up again at the health facility after about 3 to 4 weeks. So we definitely need to put quite a bit of investment on that to make sure they have their reminders, that they have somebody walking the journey with them to make sure that you go for your initial vaccine dose. And then after about 4 weeks, the same person is able to show up again at the health facility. And then of course, we have quite a bit of vaccine hesitancy concerns in the country. I mean, it's the usual concerns that most of the world is having, things around how fast the vaccine has been developed. Are we going to get the real thing here in Africa? Because we have a lot of fakes in the country. A lot of sometimes we think that COVID is a problem of the rich. It's a problem in the urban centers, not in the rural centers. So we really need a lot of convincing, especially for our older persons, to just make sure that they can take this up to reduce the morbidity and mortality due to COVID-19. And then, of course, we've also had a bit of negative reports coming from the West. I think most of us are familiar with what happened in Norway, for example, and therefore we're at a point where we wonder if you're going to be affected by the same things, and if we have the proper mechanisms to be able to track the negative effects of following immunization and what to do about it. So it's a matter of, we have capacity to monitor what happens after vaccination. Do we have the right channels? Do we have the right personnel to be able to report? So a few concerns around that. But it's not all gloom in the country. We are now preparing to roll out, to train our healthcare workers who are going to be responsible to reach out to our older persons. We have a community health workers sort of mechanism in the country, where we have community health workers attached to households, especially in the rural areas. So we have a community health worker responsible for the older persons in each of the households that we have. And therefore, once they're trained, then they'll be able to make the necessary follow-up for our older persons to make sure they get their vaccines as they are expected to get them, and that they can follow up to see if there's any adverse events. And then, of course, we're expecting our first consignment by March, which is next week. And our older persons are scheduled from July, which gives us enough time to really prepare, to sensitize them on the vaccine and make sure they're ready for it by July July of this year. So that's a very quick highlight of what's happening in Kenya. We are obviously amongst the first initial countries to get this prepared, to be amongst the first countries to be receiving the vaccine in Africa, but we trust that the other countries can also be able to catch up and be able to administer the vaccine soon as possible. Thank you very much.
Thank you very much, Jacqueline. What an interesting presentation. I can see that there is some element of commonality in a lot of the presentation around this concern with the second dose of the vaccine. Will people keep it up? Will people go for the second dose? Probably we can ask a bit more, Shalini, about that at the end when we have the Q&A. Now, I'm delighted to give the floor to Dr. Patrick Wachholz, who is talking to us from Brazil, who will give us a completely different perspective geographically on these issues. Dr. Wachholz, the floor is yours.
Thank you, Paula. Thank you so much for the invitation. It's really nice to be joining you in this important webinar. First, I would like to talk a little bit about the prevalence of dementia here in Brazil. Previous studies estimated the prevalence of dementia in Brazil to be around 1 million people living with dementia. Population in Brazil is estimated now to totals 211 million inhabitants. Previous prevalence dementia community-based studies estimated that the point prevalence was around 50 to 16%, and previous studies found that dementia remains under-recognized and under-treated, particularly in long-term care facilities. Global costs of dementia in Brazil are particularly related to the stages of dementia, and the costs were influenced by the cost of medication and the costs related to the parts. I'm sorry. This is a map that shows us the cases of COVID-19 in Brazil. The total cases of Brazil now is around 10 million, and the total number of deaths is estimated to be near to 250,000. The number of vaccinated people in Brazil is near to 7 million people. This graph is from the last week. So today we have near to 7 million people vaccinated in Brazil. This graph says something around the excess of mortality until 16th of February. In Brazil, it is estimated to have a little bit of less estimated excess of mortality, but this data does not take into account excess mortality from long-term care facilities. And this is something that we found, particularly when we tried to collect data related to people living with dementia in long-term care facilities. This is data that is really difficult to obtain. In Brazil, we don't have data sets to collect individual data from people living with dementia or just living in long-term care facilities. So it's really difficult to understand the total number of COVID cases in long-term care facilities. This is data from the beginning of the pandemic in long-term care facilities in Brazil. This is more recent data, and it's really difficult to understand how the pandemic is causing deaths in residents and in workers in long-term care facilities in Brazil. We have a little bit more cases in the state of Amazonas. This is the place where the new variant was previously found. And this is the place here in Brazil where most of the people living in the states received vaccination until today. We have from until today just 2 vaccines approved for emergency use. Yesterday, another vaccine was granted for definitive use, but we still don't have this vaccine available for routine use. We have less than 3% of the population already vaccinated. Most of the available doses, we have around 12 million doses available for a priority group that is estimated to be from around 200 million people. About 2 weeks ago, the government included more people in this priority group. They included health workers initially, and the workers from long-term care facilities, older people living in long-term care facilities, people younger who live with disabilities, and indigenous people living in indigenous lands. And then in the last couple of weeks, they included the armed forces and security and rescue forces, collective transported workers, truck drivers, air and water transport, industrial workers. And this priority group now amounts at least 80 million people. And today we have around 2 million doses available of vaccines. So this is a problem because we really don't have enough vaccine for this priority group. So it's something that the government really has to share and to create a new call for action to include more vaccines in this distribution, to have enough vaccines for all these priority groups. Thank you.
Dr. Wachholz, I mean, what a great presentation. What a shocking case is Brazil. I mean, you guys really have been hammered by COVID-19 in an amazing manner. It's good to see that there is some prioritization happening and the most vulnerable are on top of the list. I only do hope that that will be the way that things are implemented. Now I'm going to pass on to the question. Now this is quite difficult to do because we have had a lot of really amazing questions. So we have little time and I would like to focus on 2 questions. Before I do that, I would like to point out there has been a really interesting discussion in the chat line around Uganda. I really thank Esther for bringing this to our attention. In Uganda, only 2.5% of the over 75 only constitute 2.5% of the population. And as also was explained for Kenya, most reside in rural areas, and they're likely not to be prioritized. And that is disheartening because what we are saying and what we continue to say is they are the one at the highest risk. So there is a point in trying to make sure that this population that are vulnerable get higher in the priority list. And if anyone in the webinar is listening and is thinking that ADI could do something into writing to your government, help you, write jointly with you to your government to remind your government that there is the importance of prioritization, we will be very happy to take action. So do approach us, please. We are doing this because this is a practical problem. It's now and it relates to all of us. Now, somebody probably is not muted, so we are getting a lot of beeps. If I can remind you, if you're not speaking, to mute yourself, that would be really helpful. Thank you very much. Now, the first question I'd like us to focus on is a practical question that has come from a number of areas, which is if people are bedridden, so they are with dementia and they are bedridden, how do you gather consent? What do you do vis-a-vis consent? So I am going to ask first Shalini to take that question, and then I'm going to ask Fiona, and I'm going to ask Patrick to take it in turn. So could you please start, Shalini? Please keep your answer brief so we can get also the other question in. Thank you.
So I think you do have to go with the principles as laid out. We do want informed consent, and that may mean having to speak to a caregiver or speak to a dependent to understand what the individual would have wanted. I do think it's a case-by-case decision, and there may be individuals who are bedridden but capable of making a decision, and so you want to encourage that decision making. Over.
And in the UK, we've taken the same approach as we've done with any vaccination. So the same as we would do with our annual flu vaccination programme. It's exactly that. It's about consent, and if they haven't got the mental capacity to consent, then it's finding other routes to do that, usually through a family caregiver. But Paola, at the beginning of your presentation, you put some Alzheimer's Society information and links up. If people are interested, we have information on our website about this exact area and advice that we give on this.
Thank you so much, Fiona. And this is the spirit. We are all here to share. If somebody's already done it, let's not rediscover it. Let's just use it so that we can be speedier in our response. Patrick.
Yes, I guess it's the same answer. Just a little bit different in Latin American countries is that with Pfizer, BioNTech, the liability issues were a little bit different. But again, we have to have an informed consent, but the same issue about having the informed consent before giving the immunization.
Okay, well, thank you very much, Patrick. Now, there is a question I'd like to put to Jennifer. Jennifer, there is something here around whether with vaccination, the life of people in nursing home is really improving, or if it's still quite difficult to see the end of the tunnel. Would you like to take that, please?
Well, as I said, it's made a tremendous difference in our units, our nursing home advanced care unit in here. Now the first dose has been given. It has really lifted morale, but it's going to make a tremendously long time to repair the damage that's been done in the last year. Someone asked on a question whether I agreed with all this quarantining. The problem was the people who cheated, so we have to accept it. I'm sorry, I've forgotten the rest of it now.
Paola, it's Fiona. I think just to also point out in the UK that we were concerned that care home visitation was not going to open up until we had 2 doses. But we heard last week that care home visits will open from the 8th of March. So that will be one family carer that will be able to go in, so a designated key worker. So that's a huge change that we've been campaigning for. We put a petition of 30,000 campaigners wrote to the government last week, and they announced that. So that's good news. So I think 1 dose, as Jennifer has said, has boosted morale, and government has got more confidence in starting to move back to normality, whatever that new normal will be.
Thank you very much, Fiona. I know you put a lot of work in that. Now, the last question I want to ask to Jackline, and then I'd like Shalini to take it on as well, more globally. So the last question is, will distribution be decentralized? This was actually given as a question to Jackline. So in Kenya, are you going to have a centralized distribution, or will it be decentralized in whatever governmental system you have? Can you let us know, Jackline?
Yes, it will be decentralized. So we are getting everything from the central COVAX facility into our central vaccine storage, and then of course distributed to our 9 regional centers. After that, it goes to the health facilities directly.
Okay.
So what has happened? Yeah. So it's
So
decentralized, yes.
So decentralized, thank you. I mean, it seems that this is often the way for team to work really quite speedily. Shalini, can you give us your view from WHO of how that is going globally?
So a number of countries, as we talked about, have rolled out vaccine, and really it's about leveraging what infrastructure you already have. So whether you do it completely decentralized or you partially do it, it really depends on the infrastructure that's already available, and using that to come up with the quickest, fastest, safest way to do this. Over.
Well, this is wonderful. Shalini, thank you very much. We have come, as ever, at the end of our webinars. There's going to be a last slide that reminds you that you can be in touch with ADI in so many ways. Please continue to follow us on all the various channels that we know that you follow us on. We will be continuing this discourse on vaccine. This is unlikely to be the last time we're going to bring this up, because as the rollout happens, as we have heard, there are concerns emerging about our second doses working and all of these other things that is pointless for us to discuss now. We'll have to see whether any of this concern will become relevant in the months to come, and then we will reconvene. But our aim was to make sure that you were all starting from a level point. Everybody now understands what vaccines are about. We also wanted to make sure that whatever vaccine hesitancy, there's been a lot of talk around that, you had the information at your fingertip to make sure that good information is spread and not bad. We all have the right to understand our health, and this is what the WHO does. They make sure that we all can take our own decisions, but those decisions have to be well informed. And we are all in the business here to make sure that the most vulnerable get protected. So I'm sure you will continue to do a fantastic job wherever you are, and I'm sure that you will continue to work very hard. But please do use the resources that have been presented to you. Please do write to us if you want to have more information. For those who speak Spanish and have asked, is this going to be available in Spanish? There are no plans so far to translate it, but if somebody volunteers, we may be able to make the presentation of Dr. Desai available in Spanish. If somebody volunteers to translate it for us, so please do get in touch if you would like to. And with that, I leave you. Thank you once again for coming from so many countries to one of ADI webinars. Stay safe and see you all soon. Goodbye.